It's great. I love it.
Actually, I was getting to
Berglund has done a lot of studies showing that there is a huge difference between the machine implants and the rough surface implants. With ligature in the dogs, he has shown that when you remove the ligature, if you have a rough surface, you continue to lose the bone. If you have machine surface, removing the ligature without treatment, the peri-implantitis stops. And this is a very important information that we got. So why we have that? It's very simple to understand. We did a small pilot study in which we used this kind of device in the mouth of some thesis students. And we placed different implant surfaces, the machine surface, the acid-acid surface, the hybrid surface, which is machined for 3 millimeters and then is rough in the rest of the implant, and the oxidized surface. If you look at the machine surface, we have almost a clean surface after 2 days. We have a higher magnification, we can find some bacteria. And if at higher magnification, you can see some cocci, which are completely isolated. There is not a real aggregation of bacteria. There is not a biofilm. This is the hybrid. This is a machine here, from here, and this is rough here. Completely from this on is machine, from this down is rough. This is machine surface, a lot of cocci, exactly the same picture of the completely machine surface implant. Just separate cocci. But if we go here, just half a millimeter apically, you can see here that we have aggregation of bacteria, and the rough surface is almost completely covered by a layer of bacteria. And in the cracks of this plaque accumulation, you can find a lot of bacteria, much more than before in the other side. And if we look at the oxidized surface, is even worse, I would say. Here is the machine surface, which is clean, but this is immediately apically to that. And you can see that the surface is not visible anymore. You don't see anymore the typical porous surface of the oxidation. It's completely covered by bacteria. And if you go even at higher magnification, you can see that the bacteria are inside the porosity. How can you remove with the toothbrush or with a curette the bacteria from inside the porosity? How can the immunologic response get rid and fight all those bacteria which are in a porosity? And this is one of the implants that I have removed from my patients. We have a supracrestal situation, supragingival situation, subgingival situation, and the bone. And if you look at the abutment, which is titanium polished, you see that it's almost completely clean. We have some bacteria, of course, and this is the situation immediately underneath. At higher magnification, you can see a little bit of plaque here, but so many areas which are completely clean. But look at the situation here. Completely, you can see that we have a different kind of bacteria. This is a typical biofilm. And you can see out of the mucosa, supragingivally, that the bacteria are completely invading the rough surface. If we go subgingivally, it's even worse. A lot of bacteria inside, and you cannot recognize the surface anymore. And if you look at higher magnification, the porosity are completely invaded again. And this is a subgingival situation where we shouldn't see bacteria. Then if we go more apically, we have no bacteria anymore. We have just cells, leukocytes, that are trying to fight these bacteria, but they don't succeed. Deeper, more in depth, we have just bone and no bacteria at all. I just want to skip. This is another surface. This is a kind of acid-etched, sandblasted acid-etched surface. We have the same picture. So why sometimes we have a peri-implantitis and why sometimes we don't? This is just a theory. There is nothing scientific. This is just a theory. Usually when we place the implants in a thick bone and we place them synced in the bone, and we don't have any exposure of the implant surface, does not make so much difference. If we have a smooth surface, we have this kind of small defect, 1.5 millimeters as a mean. If we have a rough surface, we have this kind of a similar defect. But if we have thin bone, like in this case, and we have an exposure of the surface outside of the bone, and the surface is rough, the situation changes. In these cases where the bone is thin, or if we have a resorption of the bone for some reason, what happens is that the surface, any rough surface, progressively gets contaminated by bacteria. And there is no way to take them out, because the brushing of the patient is not effective. The cleaning from the hygienist with the curette is not effective. The ultrasonics is not effective. So there is no way to clean such a surface which is exposed outside of the bone. So what happens is that time by time you have a change of the bacteria situation, of the ecological situation. From cocci, the rods start to come, then the filaments, and then we have the biofilm, which is not a layer of bacteria, is a kind of environment in which the bacteria protect themselves. And the consequence is a progressive bone loss, which is almost impossible to treat.